the NHS letting the patients down here in the UK. We're going to discuss how it's working, what could be better, and how we have a solution to fix it. So you don't want to miss it. Grab a cuppa, and we'll see you in a minute. The NHS does a really nice job in trying to put people back together, like I said. But the biggest issue that we find is not able to cope with the TRT because of the guidance that they've created. And they've created these very strict guidance. Everything in like the UK way of doing medicine, at least it starts at the NHS, and they don't allow for any sort of diversity in thought or diversity in the ability for doctors to think empirically, like, okay, not everyone is going to fit into this very neat little box, which someone has written 10 years ago saying this is the treatment, without thinking about how do we evolve the treatment further. And that's what we run into with the NHS. The NHS says, no, we're only going to do it this way. That's the only way. Now, we think there are cost considerations. The go-to medication for the NHS is libido, normally it's testosterone and decanoate. And testosterone and decanoate, as it was studied and approved by the MHRA, is like one injection every 10 to 12 weeks. But what we know is it's not anything special. It's a testosterone molecule with a fatty acid ester that has a very long chain. Enzymes have to break this down over time, and so then they release it over time. But their secret sauce is the fact that they put 1,000 milligrams in one go, 1,000 milligrams in a 4 ml injection. So you put 4 ml or 1,000 milligrams of anything, it's still going to last a very long time. But with undecanoate, it doesn't tend to peak up as quickly as some of the other esters of testosterone that are on the market. And then it requires the patient to go in for a doctor's visit, every 10 to 12 weeks. And there's a little bit of titration in the beginning that they kind of worked out. And then they just crack on. So that requires the patient doesn't have to do the injections themselves, and they can just pop in. But that's the old-fashioned way of doing it. That's how they used to do it with the testosterone. You only have to look at one of the carry-on doctors, or carry-on doctor 2. Remember those? Have you seen those? They're kind of the British comedy, and there's a scene in that where I say dirty old girl, or this old man sitting in the waiting room, and he's waiting for his testosterone injection, and they call him, and it's so not PC anymore, and he's like groping the nurse as she's walking him to the doctor. The doctor sees this in the distance, and as he's measuring out the testosterone, he decides to reduce the amount of testosterone he was originally planning on giving him. Because, so this was back in the 60s, they had this sort of, this thing, and possibly probably from the NHS. But that was the concept. People would go in to get their injections. And modern TRTs moved away from that, but the NHS hasn't. Now, there are cases where the NHS will let you prescribe for you to self-inject at home. And they did it for me initially. I was using that cat. Briefly in 2011, 2012, I was on NHS care. And it's the postcode lottery, really. Is that, if you have a willing GP who's willing to do it, of course, and they're also, it's not just a GP, but they're also getting advice from endocrinology department. And as you know, the NHS is very hospital-centric. So nothing really goes out into the community. They're operating under a very old model. If you look at other countries, it goes out into the individual clinics. So from the NHS point of view, the fast and short of it is patients are not getting the kind of treatments that are elsewhere, like the United States, we're also serving Europe has a similar situation to the NHS, and even in the United States, if you go through the traditional insurance-based model, I don't know if you know much how the United States healthcare system works, but some of their guidance of what the insurance will pay for is very rigid as well. And so, but in the United States, because of the medical boards, they're very open-minded, and they will allow doctors to use their judgment, and other analysis, other data that's been published to justify certain treatments. And we've seen a whole paradigm shift of this in America, but in the NHS, that's not the case. So I knew this wasn't going to be ideal for men, and I knew I didn't want to live under NHS care. And I set up Balance My Hormones, founded the name in 2015. I set it up in 2016. And I'm really happy I did, because nearly every day we get men from the NHS who they present to the NHS, they got all the symptoms, they match it all up. But because they don't fit these ever-continuing lowering of ranges, that are arbitrary. They're not ranges that determine your quality of life or what an optimal healthy person should have. Then they're told, no, computer says no, you don't get treatment, sod off, or if worse, they'll just drag it on, month after month. We'll do a few more tests, but usually the people give up because they waited 6 months to a year to get treatment. So because of this, patients will come to us crying. I mean, some are really, really distraught because of what they had gone through. And it's a very traumatic experience. And they're essentially, I don't know if you know this word, gaslighting. They're essentially being gaslit by the NHS. And in some cases, other private doctors who don't know about TRT. I think we're starting to see a change, but also this is due to stigma and a lack of education and the consideration that, and the NHS treats this like a lifestyle medication rather than an essential part of health. I've taken a crack at the endocrinologists only because they've been quite nasty towards what we're trying to do. And there's a couple, you probably saw in that article, there's one guy, we'll call him Dick, who will use his real name, who happened to really besmirch what we're trying to do and really misunderstands, little narrow mind, thinks that the only legitimate testosterone is that is given by the NHS, which we know is not true. And shame on that endocrinologist, mediocre diabetes specialists. Essentially, because if they understood the role of testosterone, how it can help improve insulin sensitivity in diabetes. I mean, there may be some early fluctuations and some variations in some patients, but generally speaking, when your testosterone is optimized, when you have a deficiency, you can get an improvement, lean muscle mass. And that's not for vanity. Is there to improve your blood sugar regulation, improve you from being frail when you're older. It's there for general health and well-being. And when you start losing muscle mass, you're on the way towards death. And when testosterone is optimized in men and women, that's where I think is really misunderstood. And I think even in endocrinology, they don't really study a lot about this. And they're taught that, the only people that are trying to get this are those people that are narcissistic, or they're trying to change their bodies, or their body, oh my God, they're bodybuilders. Like, this is such a terrible thing. What's wrong with someone trying to improve their look and their health and their wellness? And yes, some people do take it overboard. But then the perception of the stigma is how much is too much muscle. And people will associate how successful someone was in building muscle. That means that testosterone must be too high. I had this happen to me, actually, in the US. A urologist I went to see, because I was thinking about switching doctors, that they had me kind of like derobe. I was just wearing, I think, just shorts. And they said, take off your shirt. So I'm kind of sitting there, in my knickers. And he walks in and met me before. And he said, hey, buddy, you got way too much testosterone. That's my American accent. I said, well, hang on a minute. Like, have you not even looked at my chart? You don't even know. No, he's like, no, I haven't, but I could tell, So I said, look, mate, this isn't going to work out. And if you're that biased towards how I look, and I was training really, really hard. Like, I was eating well. My testosterone was optimized. I had just moved to this area of Chicago. I was considering a new doctor. I ended up going to a primary care doctor, like a GP with a specialty in kind of men's health issues. And that was the best option. That was years ago. There's a certain amount of bias built into all of us. And like I told you earlier before we started, there are patients who have bias towards themselves towards this based on societal influences. The government starts with this bias by making testosterone a controlled substance. Now, why would you control something? Well, it's because it could be abused, they say. Okay. Firstly, you need a prescription to have testosterone. Okay, you have to have a prescription. You don't have a prescription, it's difficult. You can't get it. But secondly, in the UK anyway, not in the rest of not in the United States or in other parts of the world, but in the UK, it's not illegal to possess testosterone derivatives. So what happens is, and this is going to the point of the supply chain disruption, is when the supply chain's disrupted, some people will be tempted to go to the black market. So how is this good for public safety? How is this good for helping people get the medication in times of supply chain disruption? I would be an advocate for the NHS to do. I don't want to put another burden on the NHS. I think what we have to recognize is the NHS will probably change in the next 5 to 10 years in a lifetime. I think I think in this country and in Europe, we'll always have some form of universal healthcare, which is not a word that's used quite regularly in the UK, but it's a word that Americans know. And even that is a step too far. Universal healthcare, like the government's going to pay for my health insurance. What do you want about? But it actually isn't a bad thing. Essentially, rather than the government being the provider of care, because we know they can't really organize a piss up in a brewery very well. I mean, you can see how many things have been mishandled throughout, and you can see that the people in the NHS are doing the best they can with the disorganization that it is, with the funding that they've been given, and they're to be not to be blamed. But I would be an advocate, not just to say all our problems are solved by the NHS, but a collaboration between the public and the private, because I don't think the NHS's interests are aligned with the people's interests, in the sense that they're very money hungry. They're hungry to receive funds. They're hungry to receive the money from the government. And they're also determined to reduce the amount of money they're spending per patient to contain costs, so that the theory is to treat more patients. So I would argue that there needs to be a third way. There needs to be an option for affordable private insurance, when our case is cash pay. And we need to have a recognition that private sector doing TRT clinics is a legitimate and value-added service that supports the NHS by taking pressure off the NHS. So that's how we would support the NHS. Not everything has to be run through the ladder of the NHS, through the prism of the NHS. We need to have a national centre of excellence. It doesn't just look at NICE guidelines and what the NHS is doing. It should be beyond the cost. It should look at what is the best level of care. But NICE, the National Institute for Care Excellence, isn't based on what's scientifically the best thing to do. They're looking at, if we bring this medication in or this treatment in, how much is this going to cost the NHS versus what we think, based on some calculation that we've done, that it will actually improve the health outcome. And they're looking at it at this top-down view that doesn't really serve the patient's interest. All NICE does is serve the interests of the NHS so they can preserve their funding. And what we're saying is, let the private sector also, because you don't forget, in the USA, that part of the private sector of healthcare are not-for-profit hospitals, community hospitals that have a mission, a purpose, an ethical position to improve the quality of healthcare. Okay, so and so they're considered not-profit. For any organization that, and this has to be a mind shift in the UK, right? So the NHS, in so many people's minds, have become this national treasure, it's become this religion. But I'm saying, let's do what's best for healthcare, full stop. And if the NHS is a provider, great. If there is a private hospital that uses an insurance-based model, great. If there's a cash-only TRT clinic or other private clinics, fine. But let these other clinics also help develop guidelines for what makes sense, not because of cost containment, but because of what's going to actually benefit the patient. That's what I'm saying, and that's how we can work with the NHS. We'll take the pressure off the NHS, and we'll have true excellence, not with blinkers on, but true excellence based on what the science says and what might be available to all people, because everyone is so different. You can't have a one-size-fits-all. And that's how we have to change it. And speaking of hope, I hope you do like the video and subscribe to the channel, because we put a lot of time and effort to be able to bring you information that's hopefully relevant and helpful on your journey to optimal hormone balance. So we'll have some other videos. Don't forget to look at our other video if you like this topic about fears when starting TRT, fears and hopes when starting TRT, and how low testosterone almost killed me. So please check that out, and we'll see you next time.